Hi, everyone. Thank you for being here today. My name is Colin Halverson, and I'm faculty in the Center for Bioethics at Indiana University. My research for the last 7 years has focused on trying to find ways to improve care for patients with Ehlers-Danlos syndromes, in particular, looking at the psychosocial dimensions of their pursuit of diagnosis and treatment for their conditions. I don't technically have any disclosures today, but I do want to acknowledge the National Institutes of Health, which have funded my research for the last 4 years through these two grants. Without their support, I would not have been able to conduct any of the research or collate and analyze any of the data that I'll be presenting to you today. And for that reason, I'm very grateful. Mental health is a prominent issue for patients living with EDS, but it is not as straightforward as many clinicians and even patients assume. Despite its high incidence, it is often mis- and overdiagnosed. It is often treated as the cause of rather than caused by physical health symptoms. Its misrecognition can itself be traumatizing, and when clinicians rely on it too heavily, patients can internalize doubt related to psychogenesis as an acutely damaging sense of self-doubt. Despite these concerns and complications, it's important to stress just how significant mental health issues are for patients living with EDS. Based on large survey data from earlier this year, we found that while there is a slightly greater incidence of most mental health diagnoses in patients with hypermobile EDS, they are in fact higher in all types than in the general public. Particularly noteworthy, anxiety and depression were diagnosed in the literal majority of our respondents, 72% and 58% respectively, while they occur in less than a quarter of the general adult population in the United States. PTSD was additionally diagnosed in over a third of our respondents, exactly 10 times higher than the incidence in all US adults, according to the NIH. It's important to stress that at least some of these mental health challenges arise directly from physical issues associated with EDS. Chronic pain can lead physiologically to the development of anxiety, chronic fatigue to decompensation and depressive affects, etc. As we will see later, the overinterpretation of mental health issues as the source of a patient's physical concerns can be incredibly damaging, stigmatizing, and delay diagnosis even further than the average 10 or 11 years for patients with EDS. Clinician-associated traumatization is one of these issues, arising from interpersonal dynamics of clinic visits. CAT is a construct my colleagues and I developed based on interviews and surveys of patients with HEDS, in which we explored their relationships with healthcare providers over the course of their long diagnostic odysseys. I will note that based on the recent survey that included almost equal numbers of HEDS and the rarer types of EDS patients, we found similar levels of distress on all items for patients with the rare types as well. 85% of our participants in the initial study easily and immediately identified one or a small number of particularly distressing encounters with a clinician, which had stuck with them sometimes for decades and continued to shape the way they engage with their healthcare today. These participants expressed the classic features of PTSD: avoidance of hospitals and providers, negative beliefs about themselves and those providers, as well as intrusive thoughts and memories. Our interviewees described avoiding certain specialties for years, refusing to go down aisles in drugstores that triggered unwanted memories, leaving conventional biomedicine for dangerous and expensive alternative treatment modalities, and having panic attacks that lasted for weeks prior to seeing an unknown doctor. I would like to quote two such cases at length to stress the level of skepticism and distrust that patients often receive from some of their clinicians. One participant in this study described a negative encounter with an audiologist. Her mother joined us for the interview and described the experience from her perspective. After several hearing tests, she recalled, quote, "The doctor strolls in, pompous, with 5 med students. He sits down in his chair and says, 'She's faking it.' I'm like, 'Excuse me?' He's like, 'She's completely faking it.' Now my daughter's crying in this chair, and these 5 med students all looking at her, proclaiming based on her age and her sex, because she was female and at the time she was 13 or 14, that it was typical for them to fake it. I looked at him and I'm like, we've been dealing with this for over a year. She wears hearing aids. She's had multiple tests. You don't get it. We've had hearing tests at 3 different places and they all come back the same. He was just adamant. She's faking it and she needs to stop. I never went back to him. He then also called the organization associated with the School for the Deaf that advocates for kids with hearing loss go to or recommended. He went and told them she was faking it. I don't even know what would have possessed someone to be that vindictive. Ultimately, this call prevented her daughter from being admitted to that school where her disability could have been best accommodated. Another participant described a difficult encounter with a dentist. Quote, I was probably 7 or 8 at this point, and the dentist wanted to pull teeth because my mouth was overcrowded and he was doing the numbing. And I kept saying it was hurting and that I could feel it, but he didn't believe me. And then he got angrier and angrier. He called me a liar. He dragged me into the waiting room where my mom was. And then he finally gave me laughing gas, and that worked fine. But yeah, it traumatized me. In both these cases, we can see how the childhood onset of some significant symptoms related to EDS also means that these traumatic encounters occur at particularly young and formative ages. They can have a profound and lasting effect on how patients engage with healthcare for the rest of their lives. However, CAT differs from other classical constructs of trauma, such as PTSD. Physical danger associated with medical trauma, for instance, was not necessary for our patients or participants to experience these trauma-like responses. They only needed bad interpersonal interactions. And while interviewees described some truly sensationally inappropriate and even cruel encounters, such as the 2 I just discussed, the majority of instances they described represented something more on the scale of microaggressions and micro-invalidations, well below the clinician's threshold of awareness, and thus compounding rather than a single index trauma were to blame. This was something the patients themselves stressed. They believed that most of these harmful encounters were not the result of a clinician's bad intentions. Clinicians may often be inclined to refer EDS patients out for mental health support for exactly these reasons, as a way to manage comorbid anxiety and depression, as well as underlying issues such as childhood abuse and PTSD, which may exacerbate EDS symptoms or trigger EDS flares. Mental health support has also been found to be successful in managing and living with chronic pain, something that pharmaceuticals typically fail to achieve. In fact, the vast majority of the 80-some individuals enrolled in my longitudinal interview study have been or currently are supported by a mental health professional for exactly these reasons. Clinicians may not realize how informed and proactive their patients may be, and it can be frustrating for patients to receive psych referrals for their physical health complaints, especially when they have already sought out mental health care on their own. Such referrals are often experienced by patients as a form of dismissal, and when referrals are suggested without follow-through or plans for continuity of care, they may be interpreted as abandonment rather than sincere. Further complicating matters, there are very high rates of mental health misdiagnosis among the EDS population as well. In a recent study, we found that 2/3 of respondents had received a mental health label that they believed was inaccurate. In interviews, we found that these inappropriate labels are typically entered into the patient's charts not by a mental health professional themselves, but by a primary care physician or some other specialist. Patients wonder, who has the expertise and authority to make such a determination? And we, the researchers, wonder, what's the practical difference between a formal diagnosis and a label in these circumstances? Non-specialists likely do not intend their comments in the medical record to be interpreted as formal diagnoses, but they can have a similar impact regardless. Clinicians' perspectives can be biased, and patients can be stigmatized by notes such as depressed affect and anxious mother, not just by major depressive disorder and generalized anxiety disorder. Once such a label or misdiagnosis is in place, we've found it can be difficult and even impossible to fully scrub from one's record. I'm working with a grad student, Bailey Miller, on this issue currently, and her data suggests that in the vast majority of cases, despite heroic and exhausting efforts, most patients give up before having their concerns about psychiatric misdiagnosis appropriately addressed or removed from their records. In sociology, we call identity markers like mental health labels master categories, overwhelming other demographic and biographic features as the first and most significant framework through which individuals' experiences and bodies are understood. We found that the appearance of a mental health label may discourage clinicians from seeking other physical sources for a patient's distress, potentially delaying an EDS diagnosis. Postural orthostatic tachycardia syndrome may be misinterpreted as anxiety, chronic fatigue as depression, mast cell activation syndrome as eating disorders. Labels such as factitious, conversion, and functional neurological disorder can be particularly stigmatizing for patients, leading clinicians to distrust them and discount their physical health concerns. And despite their actual rarity, 20% of our survey respondents reported having received at least one of these conditions as a misdiagnosis. So we can see that EDS patients face damaging levels of skepticism from friends, family, even strangers, and most acutely from their clinicians. In a recent study, we investigated how people with EDS come to internalize others' perspectives as self-doubt. This damaging mental state leads to an unwillingness to discuss subjective symptoms like pain, as patients come to lack confidence in their assessment of their internal states. This, in turn, leads to a belief that they cannot communicate these states successfully with others. Patients therefore often downplay or even refuse to discuss what they understand to be the real severity of their symptoms. As self-report is still the gold standard for pain assessment, this means that the number one reason patients seek diagnosis and care for EDS is also likely going underreported and therefore undermanaged. Finally, and most worrisome, this doubt leads patients to internalize their belief that their private states are not, quote, real, that they are perhaps, quote, just crazy. In fact, nearly 3/4 of our participants stated that they doubt or second guess whether they are really feeling pain. This is certainly compounded by previously being labeled with a mental health condition, sometimes inaccurately, irrelevantly, or exaggeratedly. Another underappreciated feature of self-doubt that we've found in our study is that patients are not always resistant to the suggestion of a psychogenic etiology for their symptoms. Their self-confidence, broken down over compounding dismissals and microinvalidations, they may be uncritically accepting of mental health misdiagnoses, further prolonging their time to diagnosis, eroding already damaged trust in their clinicians and healthcare system, and exacerbating feelings of depression, anxiety, and amotivation. Moreover, they may even experience secondary gain from acquiescing to a clinician's mental health misdiagnosis when they initially were resistant to it. Several of our interviewees noted that they would, in fact, prefer their condition to be, quote, all in their head, rather than something they would continue to deal with for the rest of their lives. And others noted that they experienced relief when they stopped resisting a power hierarchy that favors their clinicians' interpretations over their lived experiences. Skepticism is, of course, a critical component of biomedicine, aiding in differential diagnosis, history taking, and treatment discrimination. In fact, it is often said that it is the bedrock of Western philosophy more broadly. But doubt doesn't need to express itself as dismissal. It is, as we say, bivalent. It can have two contrary values and lead patients down two very different paths. To that end, I would like to provide a couple of ethical recommendations about how to engage with patients regarding doubt or alternative diagnoses or alternative explanations for their symptoms. As mentioned, patients may experience referrals to psychiatric services as a form of abandonment. So make sure they understand your good intention with such referrals. Care in this form may be the best way to learn to manage and live with the chronic pain that comes from their very, very physically real condition, something to stress. Make plans for follow-up to ensure they know that you will continue to support their care in ways appropriate to your expertise. Don't assume your patient isn't already seeing a mental health counselor. They may consider these issues already well addressed and irrelevant to the complaint they had come to you hoping to resolve. State your belief in your patient's experiences, including their expressions of severe and chronic pain, even if you go on to suggest considering alternative explanations to what is leading to those experiences. Skepticism about symptom classification and interpretation should clearly be distinguished from skepticism about patients' motivations and capacity. Mental health challenges in EDS may arise directly from physical features of the syndrome, as well as interpersonal dynamics and compounding microaggressions and microinvalidations from clinicians over the course of their long diagnostic odysseys. Doubt is a critical component of good healthcare and should not be rejected in favor of uncritical faith. However, how you frame skepticism and alternative, especially psychogenic explanations of what a patient understands to be a physical health concern can make or break a patient-provider relationship. Small changes in communication practices, as outlined earlier, may be able to reduce their experience of stigma, avoid damaging misdiagnosis, and in the long run, strengthen the therapeutic alliance, both in your relationship with the patient and the patient's relationship with other clinicians in the future. Thank you very much for your attention throughout this presentation. I look forward to any questions, comments, and other experiences from the attendees. Thank you very much.